excellence. We shall now go on to our first speaker, Dr. Pravin Krishna, Director, the Cornea Institute, Head of Refractive Surgery, Cataract and Contact Lens Services, Consultant Cornea and Anterior Segment, who has again another great personality with an excellent academic career, an amazing number of publications and awards to its credit, and extremely astute surgeon. He would be talking on an interesting subject, femto-assisted anterior lamellar keratoplasty. On to you, Dr. Pravin.
Thank you so much, Dr. Chitra, for having me on this course, and thanks to...
You'll have to share your screen.
Yes, I haven't started yet. I also thank all the panelists and the AIOS ERC for this opportunity. And it looks like it's a fantastic group of speakers as well as topics that you've put together today, both for learners as well as for experienced surgeons. So the topic that I'm going to be speaking to you today is on femtosecond anterior lamellar keratoplasty, or FALK. FALK is something that probably has limited accessibility because you need a femtosecond machine to do this, but it certainly has its place in the management of anterior corneal opacities. So where is it useful and who might benefit from FALK? Typically, patients who have pathology limited to the anterior stroma of the cornea, like anterior stromal corneal scars or corneal degenerations that are in the anterior stroma like BSK, or corneal dystrophies that tend to be mainly in the anterior stroma like granular, will tend to benefit from FALK. Now, it's also important to choose the correct patient for FALK because FALK is not for everyone. And to do this, you should be able to choose or differentiate corneal lesions that are elevated and that are non-elevated. Let's look at a couple of examples. This is an example of a patient who has a non-elevated corneal lesion. This is haze after PRK. So the ideal procedure for this patient actually might be a PTK because the lesion is also quite shallow. So for elevated lesions like this, the ideal procedure again might be LK and not even an FALK. And I'll explain why that is so in the two case examples that I'll share with you. So for PTK, if you can actually distinguish between elevated and non-elevated lesions, if you have a non-elevated lesion and a smooth epithelium or an irregular epithelium, with a smooth epithelium, you can do something called a transepithelial PTK. Whereas if you have an irregular epithelium, you'll probably need to debride and then do your PTK. So that's the general approach when you have somebody who has an elevated or a non-elevated lesion. So this is an example of a non-elevated lesion that I showed you earlier. And if you do a PTK for this, you actually will get very good results, as you see in this picture, immediately post-op, where most of the lesion has been removed by the laser itself. But if you have an elevated lesion like this, you might actually use a different approach where you can just go and peel these Salzmann lesions from the cornea, and you will get a very good outcome like this. But then what do you do when you have lesions that are more diffuse and present in the anterior stroma of the cornea, but also are a little deeper where you can't do a PTK and you can't really do a debridement? Well, that's when ALK or femtosecond ALK comes into the picture. ALK typically is going to be covered later, but typically this is a method where you can either manually or using a microkeratome remove the corneal tissue that has the scar and replace it with a clear corneal tissue. Typically, post-ops of ALK will require sutures, mainly because of the fact that you have some amount of mismatch between your graft and your host bed. But FALK actually negates all of that because the tissue matching by making your lenticule, your donor, as well as your host bed with the femtosecond laser will ensure that the fit is extremely accurate in both these instances. This is making the femtosecond donor lenticule from the anterior stroma of a cornea. And this is making the cut on the recipient cornea using the femtosecond laser again. And because of the fact that the depth is the same and also the diameter is the same, you typically do not need to apply sutures in this. And so time to rehabilitation is very short in these kind of patients. All you have to do is dissect off the lenticule from the anterior surface of the stroma and then make sure that you place the new dissected donor corneal lenticule on the bare bed that you have and wait for it to adhere just like you would wait for a LASIK flap. So that's as simple as how FALK is. Now, the problem with FALK is if you have lesions that are scattered, you can have the laser that tends to go into the stroma quite easily. And you will have very good outcomes, like you see here in this patient with granular dystrophy, mainly present in the anterior stroma. But if you have lesions that are more dense, like this scar, what you will also see, like in the bottom picture, OCT, though the picture looks like the FLK has done a great job, but the OCT shows you that the residual bed is actually quite irregular. And this is a problem with PTA, with FALK. And even electron microscopy studies in patients with FALK have shown that the deeper your lesion is, the more irregular your cut becomes. So FALK should be limited to those patients who have superficial lesions. Let's look at a couple of case examples. This is a 25-year-old female who had a contact lens-induced bacterial keratitis. She was a myope, -5 and -4, and with a best-corrected vision of 20/40, and she wanted refractive surgery because she did not want to wear contact lenses after this episode. So if you look at the picture of the eye, you see there's a scar right in the center. And if you look at the slit picture, you see the scar is about half the depth of the cornea. On the OCT, also, the scar is about 230 microns or so deep. So we did an FALK for this patient, and we see that the scar is mostly removed from the cornea. And you'll see that structurally, it's a great outcome. But what happens is the fact that this patient still had this refractive error. Visual acuity really did not improve a lot. And the reason why this was so was because there was some residual scar in the stroma that we left behind. So what we did was we lifted the flap of the FALK, then did a PTK to the residual stroma, and then this patient had better visual acuity improvement, improving to 20/40 with correction. And eventually this patient underwent a PRK and then had a very good visual outcome with 20/25 uncorrected visual acuity. The advantage here was the fact that we added tissue with the FALK so we could ablate the refractive error later on. And that was the advantage. But then we must remember that functionally, FALK might not be the best surgery in all cases. Now, let's look at our second case. This is a patient who is a 25-year-old female who underwent microkeratome LASIK and then underwent 3 episodes of flap lift and scraping because she had epithelial ingrowth. And when we saw her, this is how her cornea looked. She had partial resorption of the flap and dense epithelial ingrowth. And you can see that this is limited to about 200 microns from the anterior surface of the cornea. So for this patient, we did an FALK again. What we did was we used the Zeiss Visumax laser, again, no financial interest. But then we created the lenticule from the host bed, and then we excised and we dissected this off the cornea. And there are a couple of interesting things that you will notice here. Once you dissect, you see the dissection is not as smooth as you saw in the earlier case, and that's because the ingrowth was relatively dense. After we removed this, then we replaced it with a clear lenticule that we sourced from a donor cornea. The patient did relatively well, and this is the patient in the first month post-op. And you'll see the OCT shows that the ingrowth has been completely removed. There is some irregularity of the stromal bed. But eventually, with time, she did really well. And she, after a PRK on the surface, achieved a best uncorrected visual acuity of 20/25 again, which I think is a really good outcome for this patient after FALK. So when you are looking at a lesion, to summarize what we've learned about anterior lamellar keratoplasty and FALK, I told you that first thing you need to do is to decide whether the lesion is non-elevated or elevated. If you have a non-elevated lesion, and if you have a smooth or an irregular topography, if you have a smooth topography, you also should measure how deep the lesion is. If the lesion is less than 100 microns deep from the anterior surface of the cornea, then the ideal surgery to do is probably a PTK because you'll only be removing a limited amount of tissue. If the topography is smooth, but the lesion is extending more than 100 microns beyond the anterior surface of the cornea, that is where FALK probably has a very good chance of giving a good outcome for these patients. If the topography is irregular or the lesion is elevated, like I said earlier, and if the lesion is less than 250 microns from the surface, you can do a manual LK that you'll hear about later. Or if it is greater than 250 microns, you can consider doing a DART. In case the lesion is elevated, then probably you should not be doing PTK or FALK, but move directly to doing a LK or a DELK. So to summarize about FALK, FALK is useful for anterior stromal scars as well as for dystrophies that are located mainly in the anterior stroma. Ensure that you limit doing FALK only for cases with regular corneal topography so that your outcome also results in a patient who has a regular cornea. Usually do not do FALK in patients with dense scars because you will get a good structural outcome, but you will not get a good visual outcome. There are some issues with interface irregularity and haze if your planning is not accurate. Sometimes you have sizing issues, but uniformly you don't need to use sutures with FALK. So you will be providing very early visual rehabilitation for these patients. And that I see is the biggest advantage of FALK over the other anterior lamella procedures or even procedures that will need sutures. Thank you very much.
Thank you, Dr. Pravin. That was an amazing talk, so crisp and clear and so well within time. I have a question to ask before I would ask Dr. Rajesh. How would you end up, what would happen if you end up with an undersized or an oversized graft, which might occur rarely, and what are the tips to avoid?
Well, I think that's the same question that Rishi had asked. So typically, early on when we started doing FALK, we always try to oversize, learning from our keratoplasty days by 0.1 millimeters. So if the host bed was 8, then the donor was 8.1. We had a few patients who had oversized grafts, and what happened in those cases is that there were a lot of folds on the Bowman's layer, and that resulted in reduction in visual acuity for these patients. So we went to same sizing grafts after that. And that sometimes lead to undersizing. But even if you have an undersized graft, the gutter that you leave behind is covered very well by epithelium. And because of the straight cut of the femtosecond laser, epithelium doesn't go under. So if it's an undersized graft, still completely okay to leave it alone. Epithelium will fill the gutter and the patient has a much better visual outcome as compared to a graft that is oversized. So typically now we just use the same size graft, donor as well as host for all. There is a little more caveat in this one because the curvature of the cornea will also affect the size of the graft. Typically, if you have a cornea that is more curved, then you will get a host bed that is slightly smaller. That's the other caveat.
Dr. Rajesh?
Yeah, actually, the point is, I was just about to ask Pravin that what he does regarding sizing, because a couple of studies have shown, they have shown 0.1 millimeter oversize, one study showed 0.2 millimeter oversize. Whatever I have done same size. And what happens that initially it shows the gutter on day one because the stroma is a bit thickened. But once the stromal thickening reduces, the edge to edge, because of the vertical side cut, that's the beauty of FALK. Which has an advantage over the microkeratome that way. Apart from the size of the lenticule, which can be customized better, the side cut vertical, since it's vertical, the apposition is very good. So I also prefer taking same size. Whatever I have done, the results were good. I feel that a step in may be better for epithelial, epithelium growing over the surface rather than step up of the host tissue, donor tissue. So that's what I felt.
Dr. Rajesh Fogla, you have anything to ask?
Well, I think Pravin has covered most of the points, and we are going to have another talk on use of microkeratome, because that is where people have confusion between using the ALTK versus using second laser. Sizing is more of an issue when you're using the microkeratome. With the femtosecond laser, yes, you can obviously go in with the same size graft. It is very important that when you are preparing your donor, you should not allow your donor to desiccate, because if that happens, then also you can have your graft shrink very quickly. And for the Zima that we use, instead of making vertical cuts, we made angulated cuts where the posterior diameter is larger than the anterior diameter. So what happens is, if I make a 150-degree cut and the posterior diameter is larger, my donor graft kind of goes into the slot. So it kind of much more secure once you have placed it without the sutures. So there, if you want, you can go in with a 0.1 millimeter larger. But then, as Pravin rightly pointed out, that even a 0.1 can sometimes feel like oversized, especially if your graft has been overhydrated. That means if you have kept your graft prepared your graft, then put it back in the donor solution, it will absorb more fluid. Then it will not only thicken, but it will also look bulkier. So when you place it in the bed, you find that it doesn't fit very well. And yes, we always have the advantage of being able to do a subsequent refractive surgery to further refine the visual outcome.
Chitra, I had just one question for Pravin. That was Pravin, apart from Visumax, which you used for FALK, have you used any other machine, and do you think are there differences in the parameters of the two machines? Because I'm sure you've done it on multiple machines.
No, I've used the Visumax as well as the FS200, and now we prefer the FS200. Again, no financial interest, just because the fact that it seems as if the laser can blow through the scar a little more easily. The Visumax is a much gentler laser, and I think the laser energy is not enough for it to cut through scars that are dense, whereas the FS generally goes through scars more easily. I've seen this being done on other machines like the AMO. IFS also, and that seems to work very similar to the FS200.
Dr. Jagdish Reddy, do you have anything else to ask? Are you there with us?
Yeah, I'm there. So, yeah, no, Pravin has covered everything. Like, I do have similar experience using both Visumax and FS200. So, I think we do follow the same protocol of having the same size, and the results have been pretty good. Yeah.
Do you all have different configurations or always go for a straight cut with FALK?
No, we in FS200 you can customize, but we prefer doing it in the straight cut. That's what we've been following, and the opposition is pretty good, so we stick to the straight cut itself.